The views and opinions expressed on this program are those of the participants and do not reflect the views of BronxNet or the program underwriters.
BronxNet. Your voice, your views, your vision.
Good evening and welcome to BronxTalk. Let's be honest, when you hear the term managed care, your eyes glaze over. It's complicated, healthcare is expensive, and what does it mean to me and my family anyway, and you and your family anyway? But the fact is, it means a lot to you and me and everybody in the Bronx, especially in the state of New York. The healthcare and Medicaid dollar is eating up a large part of our public funding pie. So tonight's guests, fresh off the renaming of their long-standing Bronx institution, have a lot to say about managed care, what it means to you and me, and to healthcare in the Bronx in general. We're on tape tonight. We will not be able to take your phone calls, but you can email questions or comments to us at bronxtalk@hotmail.com, and we'll read those on the air during a future edition of our program. Please join me in welcoming the COO of Managed Care at Beth Abraham Family of Health Services, Joe Healy. Good evening. Thank you for joining us.
Thank you for having us.
And also the Director of Community Outreach at Beth Abe, who travels around the 5 boroughs, including, of course, here in the Bronx, educating people about managed care program, James O'Neill. Good evening. Thank you for joining us. Mr. O'Neill, let's start with you. Let's not even get into managed care. Hang on, folks. We'll get there. Let's talk about Beth Abraham and this whole idea of renaming Beth Abraham Family of Health Services and why this is being renamed.
Well, I think our COO would be.
All right. Well, then let's go to Mr. Healy. Let you address that.
I think the reason for renaming our organization is the fact that there are a number of different programs that are part of the Beth Abraham Family of Health Services. We all have different names, from the Beth Abraham Nursing Home on Allerton Avenue to the 5 sites that CCM, our Managed Long-Term Care Organization, has, to the Music Institute that does music therapy for the neurologically impaired. All of these organizations are part of an integrated system of care, sort of continuum of programs for the elderly. Yet we're not understood to be connected. And the reality is we want to get our story out, because for the elderly who have long-term care needs, whether it be a need for short-term rehab, long-term rehab, services that will enable them to stay safe in their homes, we have a program that will work for them and meet their needs.
Well, I mean, I always believed that the notion of family covered that. Can I do the drum roll and what the new name is going to be?
The new name is Centerlight Health System.
Okay.
And Centerlight is an organization that is citywide at this point, 8 counties, that includes nursing homes here in the Bronx, of course, Margaret Tietz in Queens, Schnormacher in Westchester County, and the Center for Nursing and Rehabilitation in Brooklyn. It includes our adult day healthcare programs. There are 8 centers around the city. It includes our home care agency, and it includes what used to be known as CCM and will now be known as Centerlight Healthcare, which is our managed long-term care program.
So is this renaming an additional partnership that you're creating, or it's really kind of a collaboration? Just what is the center light that you've included in this dialogue?
The organizations that I was just describing are all part of the Beth Abraham family. The difference is we're now all pulled together under one name. So people will come to understand as they get involved in one or another of our programs that it's actually all part of the same organization.
Rather than, say, for example, CCM or something like that, now it's all part of
It's all Centerlight now. or will be as of February 6th.
Will you be debuting new programs along with this, or is it really more just kind of a relook at what this wonderful institution has been doing all these years?
The primary focus is to help people understand that we are all part of the same organization. But moving forward, the part that is CCM is growing considerably, expanding across the city. So the new programs really are about bringing more access to these programs to the residents of the Bronx and residents in the other boroughs.
I guess it's time to bring you into the dialogue and a terrible thing that I started the show with in this idea of managed care. You move around the city and you talk to many people about managed care, and you were very honest with me before the show, and I said, really, do they understand it? And you said, basically, no. Explain managed care in a way that people, and that's really all of us, need to know so that we can understand where it has been, and then we'll talk about some of the changes that have happened to bring us up to the current day.
Well, one of the things that played into our changing our name was the fact that comprehensive care management was a bit of a problem in that people don't like and they don't understand managed care. They think that you're going to be telling them everything they have to do, which doctor you can go to, which doctor you can't. And no matter how much you explain your programs, you'll find that a lot of people don't understand.
And I think also, especially when dealing with seniors, when you say we're doing something new or something different to something that's as important as their health care, that is a very challenging thing, and even if it's a good idea, they're immediately suspicious. How does it work now, and why is it that the governor did some reform over the past year, and then we'll break down, where it's going right now?
Well, the Medicaid redesign program, it was just that Medicaid, people who were on Medicaid and finding that they could go out and do what's called fee-for-service spending. In other words, go to the doctor whenever you want, do whatever you want at any time, and Medicaid would pay for it. The costs were prohibitive. Yet, the managed long-term care companies in the past have shown that they're able to provide quality service at reduced costs. And so by doing that, the governor said, well, maybe we should try something out. With this Medicaid redesign, that became part of the program.
What do people need to know? Again, it's probably the original document is probably like this, but give me the basics of what people need to know of how it's been redesigned and what do they need to do. I know there's a compulsion here. What do they need to do to effectively be able to ultimately access the proper services?
The way things work right now, people may get services from a variety of different programs. They may have a home attendant if they need help in the home, whether it be anything from bathing, dressing, toileting, to light housekeeping, cooking, shopping. If they need an aide, they might be getting that through a home attendant program. If they may be going to an adult daycare program for socialization, recreational therapy, meals. Separately, they may be and a little bit of urgent care. They may be seeing their physician. Right now, all of those services are provided totally independently of each other. One part of Medicaid reform is the idea that those things really need to be pulled together, coordinated. Some of the cost savings that are what Medicaid reform is about first and foremost will come from making sure there isn't waste, making sure people get the services they need when they need them, making sure they get to the doctor rather than waiting until things get to the point where they need to go to the emergency room.
All those different services that you pointed out, somebody goes to here and goes to here and goes to here. This person doesn't talk to that person. This person doesn't talk to that person. Number one, the patient, and again, many times maybe elderly or infirmed, has to somehow move the information, move the documents, and
That's
all
right.
of a sudden you could have waste, you could have duplication of services, and certainly you could have miscommunication that would cause somebody to have to start all over again, or goodness knows any number of other horrors. How is this coordinated so that the patient doesn't have to bear the burden of doing what I just said?
Well, what's going to change beginning in April, it'll be a staged rollout. So this doesn't happen for everybody beginning in April, but it will begin in April in Manhattan, And the current plan is it will start with people who are getting services through the home attendant program in Manhattan, and then it'll be phased in. There'll be a lot of education. But what is going to change? I'll use our two programs. We have two programs that are focused on people who are living in the community, and the purpose of these programs is to enable them to keep living in the community safely, having the best quality of life they can, but getting the services they need in their home so they can do that. So what will be different in one of our programs, and this is similar to programs that other organizations like ours have, there will be a nurse who is essentially their nurse, who is responsible for working with them and their family to put together a care plan that will cover all of the services that they need, whether it be that home health aide, whether it be a physical therapist coming to the home, appointments with the doctor, if they're going to a senior center for socialization, transportation to those doctor's appointments. That nurse will put together that plan with the family, and in addition to providing community nursing for that patient, that member, will coordinate to make sure all of those, and she has an administrative staff at her or he at their disposal to make sure the appointments that are needed get scheduled, the transportation comes, that everything that needs to happen happens. So for that client of ours, that member, there's one person they have to go to.
They just call that person and
That's
say
it.
the transportation didn't work, or maybe it did work and that was good, but
Right.
I need it later. I'm assuming also it refers to people coming out of surgery, let's say, who may ultimately be able to be rehabilitated and independent, but for a period of time may be alone and need some support. I'm assuming this kind of coordination can happen for
Yes,
them
they
also.
may need more services for a period of time as they're recovering, and then those services might go to a lower level.
When you go out into the community and somebody says, well, do I qualify? Am I the right person to be part of this? How do we determine who qualifies and who can access this new plan and these new services?
We actually will take a name and a phone number and then have a nurse call the individual, and they actually do an assessment and to determine whether the person qualifies. Now, to be a part of the managed long-term care program, the person has to have Medicaid. This is Medicaid redesign. So they have to have Medicaid, and that's a start of their being able to qualify for the program. But the nurse does an assessment and to determine the basic needs, the needs that Joe mentioned before, whether those needs are there. If they're there, then it's possible to come onto the program.
Can you give me some of the basic qualifications? I assume it's somebody who's elderly. I mean, give
someone
me
who is, well, if they're in our select program, which is the managed long-term care program, they only have to be 18 years old or older. Okay, they don't have to be elderly. They have to have Medicaid. They have to have a need, a skilled need that will be taken care of. They have to be, someone needs to help them to dress. Perhaps they can't prepare food, so they need to have food provided for them. They can't toilet themselves and clean themselves. These are points on the assessment that have to be taken into consideration when determining whether a person can meet the program standards or not.
And so one would think that assessment is really a critical time, because that's the moment where I say we, but the patient, but also the service provider is going to find out, number one, whether the person qualifies, but then two, which one of these different pieces of the pie they need to bring in, right?
Correct.
Mr. Healy, talk to me about what Beth Abraham, or Center Light, has to do or is doing or needs to do to put this in place? Or is it one of those things, well, we just have it and we're just simply going to do it? Or did you need to do your own set of reforms to make it work?
No, we've actually been doing this for 25 years. The program we were just talking about, we've had in place for 5 years. We have another program called PACE, the Program of All-Inclusive Care for the Elderly. We have had that program up and running for 25 years. Our first site was here in the Bronx on Allerton Avenue. And we've got now 15 sites around the city, 5 locations in the Bronx. And so we've been providing these services. The difference for us, and we have, between the two programs, about 7,000 folks we're caring for, a couple of thousand in the Bronx right now. But what's different now is people are learning about Medicaid reform. People are learning that these programs are available. And so what we've had to do is change some things so that we can accommodate more people faster.
Because you anticipate more people wanting to access it, and
it's already happening. We grew 50% last year. So the growth has accelerated. So what we're doing is we're hiring more nurses, we're hiring more physical therapists, we're hiring social workers. We are, continuously, whereas before the growth was gradual, now we are continuously recruiting the staff that we need to care for people.
I don't want to use the word pressure, but there is more pressure. The nurse is now an even more central figure in this, and of course we've heard through the news and everywhere else about shortage of nurses. But you say if somebody is a full-fledged RN, there could be opportunities here, right?
There absolutely are, especially if they have experience with home care, community nursing. The growth opportunities are pretty significant.
I don't know who's best able to explain who pays. And how is this ultimately funded? Because certainly, again, when you're dealing with seniors, there's even more concern than maybe I or even you have over who pays, because we have jobs and we're able to keep being productive and maybe raise some money. But a senior on a fixed income is like, well, wait a minute, all this sounds wonderful, but you know what? I don't have any, there's no excess in my budget to make this happen. Who pays? How does it work?
Medicaid pays. And the one thing, we're out there in the community and the seniors are amazed when we tell them that there's no charge to them. That's one reason. They have to have Medicaid. It's a Medicaid capitated program.
I was going to stand up and applaud, but I don't know.
You may.
No, but this really is good news to bring health care, and we all know how expensive it is. And also it may be for people who say, well, you know what, we don't want to keep putting money into the Medicaid system. But if it's reformed and it's effective, I think we can, I'm making an editorial comment, I think we can all see how we all benefit. You were going to add something?
Well, in addition to Medicaid, if the program also includes physician care, hospital care, truly is comprehensive, that part is paid for by Medicare. So in other words, all of their health care needs are provided through our PACE program. Everything from home care and transportation to doctors, hospitals, emergency rooms, nursing home if they need short-term rehab or a long-term stay in a nursing home. All of it is covered, paid for by a combination of Medicaid and Medicare, not by the senior.
People who are watching and saying, well, wait a minute, this sounds good. My mom, my father, my grandfather, or maybe myself, and I want to have in, I'm going to hold you because we're going to get all the access information so you know how to get in. I didn't know who was going to mention it first. You just mentioned the idea of a PACE program. I had it on my list. What is the PACE program? Is this something different from what we've already talked about, or is this something that is part of already what we've already talked about?
It's part of Medicaid reform, but the PACE program for us, that's the program we've had in place for 25 years. We're actually the largest PACE program in the country, serving 3,000 people across the city, over 1,000 here in the Bronx. It is truly comprehensive. Everything from nursing, vision, dental, social work, PT, OT, services in the home where needed, but it also includes primary care, physician specialty care if that's what's needed. It includes transportation, socialization, everything. We have 5 PACE program locations in the Bronx where people can come from for socialization. Several of those locations we also have primary care practices, or we will work with their primary care physician. They don't only need to choose one of ours. We have physicians, but we can also work with their physician. And at the heart of the PACE program, it's not just a nurse, as I was describing in the other program, it's actually an interdisciplinary team of clinicians assigned to every single client. It's a nurse, but it's also their physician, their primary care physician, social worker, physical therapist, and recreational therapist.
Sounds like a mass bit of coordination. At what point does somebody get involved, let's say, with the PACE program? Do they do that when they're well and then they just turn 62 and they retire or something like that? Or do they say, well, now various faculties are failing, or now I'm alone? I mean, at what point do we start accessing the program at they?
I think for PACE, you have to be 55. You have to be on Medicaid as with the other program, but it's usually where there's some deterioration. You don't need to wait till there's some major calamity and you need to be in a nursing home. Or
Maybe a younger person with a stroke. We know that happens.
Younger person with a
example.
stroke. It could be somebody with a little dementia who's no longer fully capable of taking care of themselves. So it could be psychological, it could be physical, no longer, somebody who's, a little bit impaired, who can still get around, but is somewhat physically impaired, and it ranges from that to, people who are seriously impaired. What we believe is that we actually can slow or either slow the deterioration in someone's health
by
if they
engaging
get
them
involved
in this program
earlier.
I was going to ask Mr. O'Neill about that. We talk about prevention. We certainly want to keep people as healthy as possible. Is there a component here that engages seniors in programs and other things before they get to a point, I guess Mr. Healy has already touched on it, before they get to a point where they really need a lot of care, which frankly is expensive for all of us, and do you folks handle things like that?
We do. If you talk to people for the Department for the Aging, they'll tell you that probably less than 5% of all seniors in the city go to a senior center. However, going to a senior center in many cases helps keep the mind active. It's something to do. Socialization is a very important part of it. A lot of the communities that we serve, especially here in the Bronx, are underserved and people are underinsured and they can't get the medical help they need. They go to a center, they find out about programs like ours, and in this case the Managed Long-Term Care Program as opposed to the PACE program, where they're going to get socialization and food right at the center. Those who do need additional help, the rehab, for example, or those experiencing early stages of dementia might be going to the PACE center. So we would transport them to the PACE center a number of times a week based on their plan of care, which the nurse has determined along with their doctor when they made the original assessment.
The 5% number is a scary one in some ways, but I'm going to make my own editorial comment that I would think that there aren't enough programs, and we always hear about making less programs than more of them. So while we certainly don't want to point fingers at people, because there may be some people who have had programs, but those programs are being cut back, and all of a sudden
Correct.
now we've got a little bit of a problem. Let's get the access information out there. So do people call? Do they email? How can they get involved with any of these programs? Or even ask the simple questions. I saw it on BronxTalk. I want to learn more about it. Who do they call and how do they go about doing it? You want to do that? You're the outreach guy. Go for it.
There's a customer service number that can be called. Or
call out that number, or Jane has it up on the screen. They're going to put it on the screen.
She has it up.
Okay.
The other way, of course, is through internet, but a lot of the seniors, people don't use the internet, or perhaps their daughters, their sons might use it to find out more about us.
Right.
In addition to the fact that almost every senior center, adult social program, we visit them. I would say on the average of 3 or 4 a day, we visit these places and we're there to tell them about the programs and to give them information. And so you can always ask there. Or
Sure. It's on the screen there, 1-888-888-38 Beth Abe, and then of course bethabe.org. And yet really you've mentioned, you go to the senior centers. That's another reason why it's great if people can go to senior centers, because they find out about services and they find out about things. Again, maybe you don't need it in a very big way right now, but it's very good to know that if you should need it, or a friend should need it, or a relative would need it, how you're going to go about doing it. Mr. Healy, I'm going to put you a bit on the spot. Are you real pleased with all of this? Do you look at it and say, you know what, this is good, but this is what we need to do with the next step? Give me a real vision, an analysis of where we're at right now and maybe where we ought to be going.
I think overall it's good because it will make it possible for people to access services through that one contact. and get everything they need taken care of. I also think it's good in our case, while we are a managed long-term care organization, we are first and foremost a provider organization. So we're an organization filled with nurses and doctors and social workers. Our focus first is on the patient and doing what's best for them. And service. And if it's good for them, if we're successful at keeping them where they want to be, in their home, in their community, as healthy as they can be, getting the services they need to stay there, that's going to be good for them. It also, as a managed care organization, will be good for us because it will be more cost effective. But I think the challenge that we all have ahead of us with reform is, and we've been talking about it tonight, is the education that needs to happen. There are people, well, and that's also where I think public leaders and where communication coming out of the Department of Health, and there needs to be
TV shows like BronxTalk.
Yeah.
Definitely.
Exactly. So there needs to be a lot more information for folks about what's going to happen and when, and what, as you've been asking, and so what do they need to do?
Right, and because, as I said, everybody says managed care, and it's like, I don't even know what it is. But here, I mean, I've learned as well that this idea of coordinated care, of course, makes a ton of sense. What's the number one question you get asked when you go out in the field, and what is the thing that people are just, what do I need to know? What do I need to do?
Do I have to give up my doctor?
And your answer is?
Is if you're a part of our select program, you do not. Because in the managed long-term care program, you keep your primary physician, and the nurse coordinates your plan of care with that physician. If you're in a program like PACE, which is the all-inclusive program, then you select from a book of physicians who are at the center that you happen to go to. But that's the number one question.
And we can also, sounds like you have a good answer to it.
Yeah, and we can also, I mean, if there's a physician who has a significant number of elderly folks, we can, even for PACE, we can contract and work with that physician.
888-BETH-ABE and bethabe.org, but the new name is?
Center Light.
Center Light. We're going to see it everywhere. Maybe they'll even change the phone number. I don't know. We'll say to James O'Neill, thank you, and to Joe Healy from currently BETH-ABE, soon to be Center Light. Thank you for informing all of us. I think it's real important, and it'll keep us all healthier for a lot longer, and that's a good thing. Folks, if you have further comments or questions on anything you heard on tonight's show or anything going on in the Bronx, and email them to us at bronxtalk@hotmail.com, and we'll read them on the air during a future edition of our program. Archives of Bronx Talk are available at bronxnet.org. You click a Bronx Talk on the right-hand navigation bar. Now, we've got a great lineup of shows coming up. Next week, February 6th, we go to the roads with the AAA. We'll talk about the rise in tolls, lighting on our roadways, and a number of other traffic, road, and street issues should relate to each one of us. Then on February 13th, the leading parks advocate will join us to talk about the new golf course, an old golf course, a proposed skating rink, parks funding, or the lack of it, and a number of other Bronx parks issues. Please make a note that the borough president will be our guest on February 27. He'll talk about his State of the Borough address. We have a lot to do. Monday nights at 9, Bronx Talk here on BronxNet Channel 67, Verizon Fios Channel 33. Thanks to producer Jane Folloro, director Michael Arias, and our cast of thousands up in the booth and around us here. And to you, good night. See you.